Okay, exciting times. Last concept for the semester is the concept of mobility, which is on page 879 in your book. So let's begin. We need to assess mobility and we need to understand what is normal about mobility. My suggestion, go to the mall, watch people. You'll see what I'm talking about. There are many different issues that we can run into as a nurse when we are assessing someone who has mobility. We need to realize that we have to have participation from the skeleton, from the muscles, the joints, the ligaments, the tendon, and the cartilage. All have to be intact and working. Also on page 879, the learning outcomes for mobility. Take a minute and review these. Okay, so let's turn to page 881, Alterations and Therapies. We're going to take a look at herniated disc, fractures, and scoliosis. Our exemplars are multiple sclerosis, OA, which is osteoarthritis, and PD, which is Parkinson's. Realize that we will cover spinal cord injuries and adult health too. So first let's talk about herniated discs. We are talking right here, this picture with herniated disc. And when we look at a herniated disc, what you're going to notice is that you have the disc has actually ruptured possibly or is at least bulging, and this causes back pain, but often it also impinges on a nerve and causes nerve pain, and it can also cause alteration in sensations. This is all dependent on which level the herniated disc is located at. And so when you're looking in the book, it gives you signs and symptoms, and then it tells us what we need to do as far as treatment for the herniated disc. Conservative treatment, rest. We can try some medicines. Often we try NSAIDs, opioids, muscle relaxants. Could initially try a round of steroids to decrease the inflammation. Certainly physical therapy, and we could also move to surgery if the conservative methods are not successful. Next we look at a fracture. You can tell obviously that this bone is fractured. You can also tell that this bone is displaced. And so you guys understand what a fracture of the bone is. You understand that it can happen in any bone that we have in our body. Also, a couple of terms that we're going to learn is simple versus open. And so a simple means the skin is intact, and open, you might know this as a compound, means that the bone has interrupted the skin. And then we're going to learn displaced, which this fracture is obviously displaced, versus non-displaced, where the ends of the fractured bone are actually together. We'll talk a little bit more about fractures on the next slide. So next, we're going to talk about scoliosis. Scoliosis is a lateral curvature of the spine, typically an S shape. We're concerned with this condition in the adolescent population, and while girls and boys have equal percentages of scoliosis, it is the girls that typically have a greater incidence of having a larger curvature that requires intervention. So scoliosis is something that we need to monitor for in middle school, the middle school population. We look for uneven hip bones, and in particular we look for clothing that does not seem to fit properly. When you're looking at the interventions and therapies for scoliosis, you can see that we catch it with regular checkups, and often we provide a back brace to help prevent further curving and exercises to actually improve back strength. As far as surgery to correct the curve, this is only done in severe cases. Okay, so let's just talk a little bit more about fractures. So first of all, RICE versus police. So RICE is what we're used to using, rest, ice, compression, elevation. We typically use this in the first day or two. we knew that it helped decrease the pain and the swelling and the inflammation. But they changed the acronym to POLICE, and this was to actually include protection and optimal loading, or the load which we can apply to the structure that's been fractured, and it will maximize the physiological adaptation, which also helps to promote healing. So we have POLICE, the P for protection, the O and the L for optimal load, and then we go back to the ice, the compression, and the elevation. When you're looking at a fracture, then we have to look at how are we going to fix it, right? And so you have what we call closed reduction. Closed reduction just means there's no incision. We merely use manual traction to place the fracture back in place where the ends of the fracture meet. This is done now under monitor anesthesia care, and then it needs to be immobilized, a splint or possibly a cast. An ORIF is an open reduction and internal fixation. That's performed under general anesthesia or possibly a regional anesthesia. It brings the displaced ends of the fracture into alignment, and then to stabilize them, we put in some hardware. Now, if you guys look at page 920 in your book, there's some great examples of the different types of hardware that might be placed. This hardware can often be taken out at a later date. It talks next about external fixation, another great picture of external fixation in figure 13-28 on page 920. External fixation uses pins that are placed above and below the fracture, and it is used for complicated fractures. We have to make sure that there's sufficient patient teaching for someone who has this type of device, and that's outlined on page 922. Cast and splint is just a way to provide immobilization, and immobilization always supports healing and hopefully will decrease the risk of having a complication. So just remember, if you have someone who's going home in a splint or a cast, you want to make sure that you teach about the 6 Ps and about when to notify the healthcare provider. So for instance, we send someone home with a cast, they should be able to get a finger under both the distal and proximal end, and they should note that if their hand would become cold, more painful, numb, have pins and needles sensation, turn pale, or they're unable to move their extremity, this would warrant a call to the healthcare provider. Complications. Anytime someone has a fracture, there's always the risk for complications. These are also very dependent upon the type of fracture and how the fracture was repaired. So there is a great chart in your book that outlines the different types of complications and how we treat them, and that is on page 919 in your book. It talks about osteomyelitis, which is an infection of the bone. That's always a risk when we go in, for instance, and do an ORIF or external fixation. It would have to be treated with IV antibiotics for several weeks. Compartment syndrome manifests itself by alteration in the 6 Ps, especially pain. You have someone who was doing pretty well, the pain medicine you were giving them was working, but all of a sudden it doesn't seem to be touching the pain. That could be an instance of compartment syndrome. It helps to know this goes along with more complicated fractures. And then a fat embolism is a particular type of syndrome that we see with fractures, but particularly fractures of the long bone. And the best way to prevent a fat embolism is to make sure that you immobilize the fracture as quickly as possible, and you make sure that the patient understands that the fracture needs to stay immobilized. And then lastly, a DVT, and you guys certainly understand what DVTs are and how to assess and treat DVTs. Okay, there's terms that you guys can take a look at on 883 and 884 in your book. Also, there is a few considerations as far as genetics and risk factors for the concept of mobility. As usual, the number one risk factor for having an issue with mobility is age. And we know that as we age, that the elderly are at a higher incidence of having, for instance, OA, lower back pain, inflammatory disorders. We also understand, though, for genetics, there's a box on page 885, box 13-1, that outlines some of the genetic considerations that affect mobility. So, for instance, muscular dystrophy is characterized by a progressive weakness, and this can certainly alter mobility. Marfan syndrome is a connective tissue disorder that can alter mobility. And then we're going to actually talk about, MS and Parkinson's. They can both alter mobility, as well as lupus, and as well as ALS. Okay, related concepts are listed on page 887. I didn't list collaboration, but certainly it ties in closely with mobility. If we have someone who has an issue with mobility, we certainly would want to refer them to an OT, a PT, maybe a personal trainer, get a nutritionist involved. I did list comfort if we have someone who has altered comfort. For instance, someone has a fracture, they have increased pain, then decreased activity leads to muscle atrophy and leads to bone resorption. So we have to make sure that there's adequate pain medication management, adequate calcium intake, and encourage what exercise they can do. When we look at health, wellness, illness, and injury, good thing, increase physical activity, increase muscle mass, increase strength, and bone density. So encourage physical activity. Mood and affect. If we have a decreased sense of self-worth or perception of life, then we have an increased risk of depression, which could lead to a lack of mobility, and then this could lead again to muscle atrophy and bone resorption. So we want to assess mood and affect and discuss any signs and symptoms they might have regarding their own self-worth and perception. Safety goes across the lifespan. We know that there's safety risks, for instance, when infants are learning how to walk, how to crawl. They're at risk for having falls, for drowning, having a head injury. We know that adolescents, they're involved in sports, and so they are certainly at safety risk for fractures, for strains, for sprains. And we know that the lifespan considerations of the elderly lead to an increased risk of falls. And then stress and coping, we know decreased mobility causes an increased stress in our patients, and they could have a difficult time coping with this, and we certainly would want to assess for this. Certainly, we want to observe when the patient arrives how they're walking, their mobility, any evidence of pain. We want to ask them about their past medical history, any type of diseases that would affect their mobility, Parkinson's, MS, ALS, OA, osteoporosis, fractures, etc. Ask them about their current visit, why they're there. Are they having pain? If so, have them describe it. Also, ask them about any symptoms that are associated with the pain, how they've been treating it, and how the injury occurred. We want to talk to them about lifestyle, especially for mobility. It's important to understand what's normal for their mobility. Do they use any assistive devices? Do they exercise? If so, how often? How much? What's their diet like? What's their source of calcium intake? Any drugs that they use? Any drugs that might affect bone density? Do they smoke? Do they drink, which can also affect bone density? When we're looking at the physical exam, we certainly want to assess pain, and we want to assess the 6 P's. Your book actually just goes over the 5 P's, but you guys understand you've learned the 6 P's. You can grade muscle strength, which is on page 888. There's a table. But you have to realize many of the different assessment techniques that they have placed in this chapter are actually held for advanced nurse practitioners, and that typically goes along with grading muscle strength, muscle function. The assessment goes on page 889. It talks about doing a physical assessment where we're checking for any types of deformities, any tenderness and pain over any joints, bones. Also looking at their gait and posture, as we've already talked about, making sure that we're looking for any curvatures of the spine to include, we've talked about scoliosis, but also kyphosis and lordosis. Ask about joint pain. Look at joints. Is there any joints that you can tell are actually warm, reddened? There's any crepitus palpable? Then you have to realize that they go into, on page 890 all the way through 892, going through very specific types of assessment techniques for the various joints, and you guys will not be held accountable for those. If you look at the bottom of page 892, there's a couple of simple ones, and certainly one of them is called the Fallon's test, and the Fallon's test is depicted in 1313, and that actually helps check for carpal tunnel syndrome, which is a repetitive use injury. And then it wraps up on page 893, but again, getting into very specific tests that help to identify any issues with the knees or the backs, and you will not be held accountable for that. When we look at independent interventions for mobility, there's a real focus on education. Certainly, there's so many things that we could provide education. Certainly, we can provide education regarding ambulation, when someone can return to ambulation, proper posture and body mechanics. We can also talk to them about how to use the various assistive devices that possibly have been prescribed by the HCP. We want to talk to them about comfort. We already talked about police, but we want to talk to them about the use of ice within the first few days of an injury. Talk to them about joint padding, encourage them to properly use their braces or supportive devices that have been prescribed by the HCP. Encourage them to stretch and to also participate in exercise that helps prevent muscle atrophy, contractures, and just encourage independence overall, not overdoing it, encouraging the patient to do as much for themselves as possible. By encouraging independence, then we also avoid, hopefully, social isolation. And so we just, the more mobile, the more independent an individual is, the less likely they are to suffer from social isolation. And then, last but not least, we certainly want to make sure that if they've received prescriptions, medications, that we want to talk to them about the medication, what they're taking it for, how it works, side effects, and any precautions that we might need to include in that teaching. Okay, moving on to collaborative therapies. When we look at collaborative therapy, we talk about exercise in general. We understand that exercise helps strengthen muscles, prevents atrophy. We certainly want to avoid prolonged bed rest. We want to encourage passive and active range of motion. Resistant exercises also increase muscle strength, as well as isometric exercises help to maintain muscle strength and are incredibly important when a joint is immobilized. We need to make sure that the HCP has offered referrals for rehab services. We want to make sure that the OT and the PT are involved. This helps to preserve and regain mobility. We want to encourage ambulation with or without assistive devices as soon as possible. We understand by encouraging ambulation, we're decreasing risk, the risk of developing osteoporosis, the risk of muscle atrophy, developing a DVT, an infection, constipation. And so ambulation just overall improves function. It improves your sense of well-being, your strength, and is important just to be able to ambulate to do your ADLs. We also want to make sure that if we see a need of an assistive device, that we pass this along to the HCP so it can actually be ordered. When you're looking at diagnostics, you guys know most of the diagnostics, there's not too many things that I really need to bring to your attention regarding diagnostics. You guys understand x-rays, CAT scans, MRIs, certainly a DEXA scan might be used to check for osteoporosis, a bone density scan. As far as blood testing goes, we have talked about most of the various types of blood tests that you guys would need to understand. There is a chart that is listed in your book, and you can look through that to see. Nothing new that I want you to learn. The page is 894. The table is 13-2. You can see that there is what we call the HLA-B27, and that just is to check for spondylosis or arthritis, but you don't need to know that. The rheumatoid factor may or may not be present when someone has RA or scleroderma or lupus, and uric acid is something that we often check for the presence of gout. So that's the good news. Nothing really as far as diagnostics. Meds, that's also pretty much good news. There's not a lot of new meds that you guys haven't learned yet. Page 898 talks about NSAIDs. We've already talked about NSAIDs. You guys know about NSAIDs. We get into antispasmodics, then meds are on page 898. Good news, you guys know the NSAIDs. Move on to the antispasmodics. You guys know them as muscle relaxants. The cyclobenzaprine, you guys know as Flexeril. And then the baclofen. Those are the two that I would want you to know. They're the most popular. These guys just decrease nerve transmission to the skeletal muscles, and they provide relief from muscle spasms, but they do have CNS effects, and so we have to be extremely cautious. They can cause also orthostatic hypotension and can cause people to be drowsy, so they should avoid hazardous activities. And looking at the direct-acting antispasmodic drugs, these guys actually decrease the release of the acetylcholine, and so therefore you have decreased skeletal muscle contraction. And these guys do not cause as much drowsiness as the actual antispasmodics. And so because of that, sometimes they are a little bit more effective if someone needs relief during the daytime. And then the bone growth stimulators, these are the biophosphonates, and these are the drugs that we use for osteoporosis. And so the aldronate is what you guys are probably most familiar with, and these are given to people who have a bone density scan that shows that they have osteoporosis, which increases the risk of fractures. And so we have to be careful in how these medications are actually administered, and that they should not be administered with calcium. They should also be taken with a full glass of water, and the patient should remain upright after taking them, because they can cause really some distressing GI side effects, and that we have to be cautious in the patient who has renal or liver impairment. Okay, lifespan considerations. For the infant, you guys know this. You learned about the fontanelles and probably mother, baby, and peds. You know that the fontanelles are not closed at birth. This is necessary. It provides flexibility so the brain and the head can grow. And so they close, the various fontanelles close between 1 to 19 months of age. We look at children. You're looking at a population that has rapid growth of the bones. This is awesome, quicker healing of fractures, but often leads to what we call growing pains. And then as far as adolescence, skeletal muscle maturity is about ages 18 to 25, and gradually as someone matures, the percent of body weight from the skeletal muscle increases from 25% to, when we're an adult, up to 40 to 50% of our actual body weight. And then all the wonderful things that we have to look forward to as we age. There are multiple changes that occur in the musculoskeletal system that affect mobility in the older adult, and some of these are actually listed on page 901. To hit the highlights, one, there's a decrease in bone density. This leads to an increased risk of fractures. 2, the spinal disc becomes thinner, and this can lead to increased incidence of back pain and spinal stenosis. We have natural atrophy of the muscle fibers, so we have less tone and decreased speed and power of contractions, and overall this leads to decreased strength, a slower reaction time, more time to, it takes more time to train an individual, for instance, that's elderly, that has muscle weakness. It also impairs their balance. And then we have stiffness in the ligaments and the tendons, and so we just wake up stiff. We have decreased joint flexibility, decreased range of motion, and certainly ligaments and tendons could tear more easily and then require a longer time to heal. Last but not least, we have just an overall decrease in activity and tolerance, and this can lead to a greater recovery time from issues that might lead to impaired mobility. Okay, that wraps up the concept of mobility. Thanks for listening. You guys know where to find me.